Welcome to AETCM, the Emergency Medicine channel. Today we will be discussing about acute diarrheal diseases. As we can see here, what is acute diarrheal disease? It is defined as a change in the consistency of stool leading to liquid stools or an increase in the frequency of evacuation, that is 3 or more than 3 times in 24 hours is termed as acute watery diarrhea. So this is the definition given by the Pediatric Association. So coming to the next slide, that is the causes of the diarrhea. Acute diarrhea in children, the main causative reasons are, first one is the infective causes, and in infective causes mainly it is 60% is contributed by the viral causes. Among the viral causes, the most common is the rotavirus. It can be also caused by the norovirus, adenovirus and the other viruses. Then coming to the bacterial causes, it can be caused by the salmonella, shigella, Vibrio cholerae bacteria it can cause. Coming to the parasitic causes, it can be caused by the entamoeba, giardia, etc. These are the most common infective causes. Then coming to the other causes, mainly any anatomical issues are there. It can also cause acute diarrhea in pediatric age group, such as if there is any intussusception, if there is Hirschsprung disease, if there is any small bowel disease. These the children are also predisposed to cause acute diarrheal disease. Then if there is any inflammatory bowel disease, if there is any systemic disease such as hyperthyroidism, parahypothyroidism, if there is any adrenal insufficiency syndrome, those children also can develop. Then in case of any intake of antibiotics for longer duration, those children are also predisposed to have acute diarrheal disease. And coming to the acute diarrheal disease management in ER.
So another cause is any intolerance, lactate intolerance or anything, or even malnutrition and overfeeding can also cause diarrhea.
Disease. If there is any overfeeding, if a child is having any allergic to any food substance, they also can cause the diarrhea. Now, when a child comes to our ER with the acute diarrhea, initially we have to see the signs and symptoms of the child, and then we have to classify the child into no dehydration, some dehydration and severe dehydration. In severe dehydration itself, we have with shock and without shock. So, any child coming, we will be looking for the symptoms, and mainly we will be assessing the mental status of the child. So, in no dehydration, if the mental status will be normal, in some dehydration the child will be very much irritable, and in severe dehydration the child will be lethargic, and in the later stages can go into unconscious state. Then coming to the thirst, in no dehydration child will be having the normal, in some dehydration child will be very much thirsty and will be eager to drink water, and in severe dehydration the child will be not able to drink water. Coming to the vitals such as the BP, pulse rate and the respiratory rate, when there is no dehydration, all these vitals will be normal. In some dehydration also it will be mostly normal, BP can go into a lower side, pulse rate can slightly increase, and in severe dehydration all these parameters will be affected, such as the child can develop hypotension, child can develop tachypnea and tachycardia. Then coming to the other signs which we can elicit on the child, that is the anterior fontanelle. Anterior fontanelle, in case of no dehydration it will be normal, in some dehydration it will be sunken, and in severe dehydration it will be very much sunken. Coming to the eyes, it is same to that of anterior fontanelle, it will be normal, sunken, very much sunken. Coming to the tears, in no dehydration it will be normal, in some dehydration it will be reduced, and in severe it will be absent. Then buccal mucosa also, it will be normal, moist, then in some dehydration it will be dry, and in severe dehydration it will be parchy. Coming to the most important things, that is the skin turgor and the capillary refill time. In no dehydration it will be normal, in some dehydration it will be between 1 to 2 seconds, and in severe dehydration it will be more than 2 seconds. Then coming to the peripheries, in no dehydration it will be normal, that is the warm peripheries will be there. In some dehydration it can be warm or mildly cold, and in severe it will be cold extremities. In the urine output, no dehydration it will be normal, then in some dehydration urine output will be reduced to less than 1 ml per kg, and in severe dehydration it will be reduced to 0.5 ml per kg.
Okay.
So these signs and symptoms you will look for in the child and then classify the child into as no dehydration, some dehydration and severe dehydration. So then coming to the treatment plan.
So when will you classify this child? When will you assess all these things in a patient? So initially when a child comes to here, what will you assess first?
First, any pediatric child coming, we will have the PAT triangle assessment, that is the 10-second assessment. So in that you will be looking for the appearance of the child. In the appearance you will be looking for the tickle, that is the tone of the child, whether the child is the interaction of the child, then whether he is consolable or not, then the look or the gaze of the child, and then the cry of the child. Okay. So these things you will be looking into the appearance of the child. Then you will have to look for the work of breathing, whether there is any increased respiratory rate, whether there is any usage of the accessory respiratory muscles such as ala, nasa and the external and internal intercostals. Then coming to the color of the child. So you will be looking for any pallor, cyanosis or mottling in the child. So, and then you will be also taking a brief history of whether.
So first we will be checking the PAT triangle. Then we will be looking the primary survey. And when will we check all these things?
When the child already you have an history of acute diarrhea, and also the child is.
So that is coming as, so first we will check the PAT triangle, primary survey, sample history, followed by this. This is actually our head to foot examination. So from head to foot, how will you start?
So from head to foot, you can start with the anterior fontanelle. You will be starting. So looking for the anterior fontanelle, then you can look for the eyes.
That I will draw. So if this is a child. It's not coming. Okay. From the head. Okay. So in the head we can look for the anterior fontanelle. Along with that we can look for the mentation of the child. Okay, mentation. That will be checking the head. Then eyes
and the tears.
Eyes we will be looking for the eyes and tears will be. Okay. The mouth,
buccal mucosa, you can look for the moist or dry.
Okay.
That you can look.
Then when we come down here, we can look the vitals. We can reassess the primary survey. That is the vitals of the child, including the CRT, blood pressure. Then the chest region, we can look for any mottling. That can be seen in periphery also. Any mottling of the child, any abnormal breathing pattern, especially if the child is going into acidosis, severe acidosis, then any acidotic breathing. That is for the chest region. Then in the abdomen, what will you check? Skin turgor and urine also. You will have to check for the urine. Then the peripheries, again the CRTs, rest of the things can be assessed. Okay.
So these things will be assessed.
Okay. So when will you tell what all are the red flags of acute diarrheal disease?
Red flags, if any of these vitals are deranged, then that is a red flag. Then if the child gives a history of bloody diarrhea, that is if it is an invasive diarrhea, it is a red flag. Then history of fever, then history of persisting diarrhea more than 7 days associated with vomiting. Those are the main red flags. Then mentation, any altered mentation.
Okay. Or any history of jaundice, severe abdominal pain, or if the child is presenting with any petechiae, pallor, any blood in vomitus or blood in stools, or if the child is a neonate also, we will have to consider it as a red flag. Okay.
So once the child comes and we look for these signs and symptoms, and then we classify the child into no dehydration, some dehydration, severe dehydration, then we will start with the treatment of the child. So coming to the treatment part of the child, we have plan A, plan B and plan C for the child. So accordingly we have told that in plan A, that is when there is no dehydration, the percentage of body weight loss will be less than 5%, and the estimated fluid deficit in the child will be 50 ml per kg. So here there are two mainstays of treatment, that is there should be a maintenance therapy and a replacement therapy. In replacement therapy, what we deal is how much ever loss is there, that we will try to correct. That is, if the child is having 50 ml per kg loss, that loss we are trying to correct. So that is the replacement therapy. And second one is the maintenance therapy. Maintenance therapy is when the child is having ongoing loss, that is after that whenever the child is having loose stools or vomiting, for each episode of that we will give a correction. That is called as the maintenance therapy. So in plan A, when there is no features of dehydration, the only goal is to correct the maintenance. That is whenever the child is having a loose stool or vomiting, we will be giving fluids for the child. And for that the preferred is the ORS, oral rehydration solution, and the child can be managed on home basis. So for every loose stool, episode of loose stool, we will be giving 10 ml per kg to the child. And when the child is less than 2 months, we will be giving 5 teaspoons of the ORS solution. And when the child is 2 months to 2 years, approximately if you take this 50 ml per kg, it will come to 50 to 100 ml. And when the child is between 2 to 10 years, it will be around 100 to 200 ml. And if the child is above 10 years, as much as the child can intake, how much ever the child is tolerating, that much fluid you can give. So here you will be only giving the maintenance solution, and preferred is the ORS.
Okay, so preferably what you can do is for every loose stools we will give 10 ml per kg.
And for every vomiting episodes you will be giving 2 ml per kg.
2 ml per kg, that is for vomiting. What if the child vomits again?
If the child is vomit again also, wait for 5 to 10 minutes and then repeated doses of ORS can be given. Vomiting is not a contraindication for the oral correction.
Okay, so what all are the different types of ORS?
We get ORS sachets, the new ORS sachets available, and in that ORS sachets we have glucose and sodium will be of equal volume, and it will be 75 millimoles per liter. Then in that we have potassium, which is 20, we will also have chloride, which is 65, and citrate of 10. So these are the compositions of ORS. If we are making it in the home, then we can take 1 glass of water, add 1 teaspoon of sugar and 1 pinch of salt, and then you can use, and this should be used within 24 hours. After 24 hours this should be discarded.
Okay. Any home solutions other than
this? Otherwise we can use any rice water, salted rice water can be used, any soup, vegetable soups can be used. Then you can give salted lemon juice or coconut water, but coconut water and lemon juice not ideally preferred,
because water solution we are taking should contain sodium and glucose. Why?
Because glucose dependent sodium channels are there, so in order that glucose and sodium should be of equal amount.
Okay. Or we can use yogurt with salt.
Salted yogurt also can be used.
Okay.
Then if it is plan B or plan C, both these children should be admitted and treated in the hospital itself. So in plan B, the deficit of fluid will be 50 to 100 ml per kg. So here you have 3 corrections, that is the daily requirement should be given, the whatever it is the deficient, that replacement dose should be given, and also the maintenance for each purging and vomiting. Those 3 corrections should be given, and here also we prefer oral correction. ORS itself is given. So first, daily requirement according to the Holiday Haggas formula, that we know that for the initial 10 kilos we will be giving 100 ml per kg, next 10 kilos we will be giving 50 ml per kg, and further kilos we will be giving 20 ml per kg dose in 24 hours will be giving. So according to that daily requirement will be given. Then coming to the deficit correction, we will be giving 75 ml per kg over the 4 hours. That correction will be given, and then maintenance therapy will be given, that is similar to this, 10 ml per kg for each stool and 2 ml per kg for each vomiting episodes. Along with these corrections, if the child is a breastfeeding child, breastfeeding should be continued. If the child is not breastfed and is less than 6 months, you can give 100 to 200 ml of clean drinking water. And if the child is a bigger child, how much ever fluid he wants to take oral, that can be also given to the child. And once this correction, this child should be monitored every 1 hourly, and once this 4 hour correction is over, then you have to reassess the child and look whether the child is having some, again you have to classify the child into no dehydration, some more severe, and then the treatment plan has to be changed accordingly. So then coming to the severe.
So in plan A and plan B, what we need to summarize is, here the rehydration therapy is oral. Okay. Only in plan C we are considering IV. So why oral is considered better than IV?
Orally, it is, if the child is already tolerating oral fluids, then you can give orally. You need not put an IV access and disturb the child. And
that is one reason.
Then if it is planned in the home basis only, you can treat the child.
Okay. Any other advantage? If we are taking orally, the gut mucosa, mucosa will be healed, and along with that the amount of vomiting and loose stools the child will have will also reduce. And if we are giving IV, what is a disadvantage? The children might go in for a cerebral edema, fluid overload, and that can also be prevented. So better always give oral.
Okay.
Only if the child in severe dehydration, child will be very lethargic, so child won't be able to take orally. In that condition only we will be considering IV. Okay.
Then coming to the plan C, here the estimated fluid deficit will be more than 100 ml per kg. So initially we will have to admit the child into the hospital and treat with IV fluids. So as we have told earlier, daily requirement will be given.
So anything else you need to consider before going to severe dehydration management?
If the child is in severe dehydration, we have also an WHO classification protocol. So when the child comes to you, you will have to look whether the child is having severe anemia along with this. So if the child is having severe anemia, that is if the child is from a malarial endemic area, if the HB is less than 5, or for normal children when the HB is less than 6, you will have to first give anemia correction for the child. And if you are giving the whole blood, you will be giving 30 ml per kg over 4 hours, and if you are giving PRBC, it will be 15 ml per kg over 4 hours. And once this anemia is ruled out, you will have to look for severe acute malnutrition in the child. That is, you can look the upper mid upper arm circumference if it is less than 11.5 centimeter, or if there is weight for height, that is the Z score is less than 3, or if there is bilateral edema. Any of these features are there, we will term it as severe acute malnutrition. And in case of severe acute malnutrition, you will be first treating the child with Risomal. You will never give the child ORS, because in ORS we have more amounts of sodium and less potassium. But in severe acute malnutrition, we want less sodium and more of potassium. So we will be treating the child with Risomal. We will not be giving the child with ORS. So once this anemia and severe acute malnutrition is ruled out, then you can go into plan C. So we will be going into plan C, and in plan C also you will be looking whether the child is in shock or without shock. When the child is without shock, you can go for the correction, that is the daily requirement will be given. You will be giving how much ever deficit. That deficit will be given like when the child is less than 1 year, you will be giving a total of 100 ml per kg, and that will be divided into 30 and 70. First 30 ml will be given over 1 hour and rest 70 will be given over 5 hours. When the child is more than 1 year, you will be giving it over half an hour and 2.5 hours. Just half the time you will be giving the fluids. And if the child is taking
that is IV. That is IV. So IV, what fluid will you give?
Preferably we give crystalloids, that is the RL or NS can be given for the child.
Ideally for children, better to give 0.45%, that is half NS. 0.45 NS can be given along with
dextrose also
can be given. How much percentage?
5% dextrose can be given.
2.5 to 5% dextrose should be given. Dextrose plus potassium. If at all any potassium correction required, that should be given. Okay. But for bolus dose, we might not use potassium. For maintenance, we will use potassium.
So, and if the child is orally tolerating, then you can, along with this IV correction also, you can give ORS at the rate of 5 ml per kg per hour. So, this is the corrective dose for the plan C, and then here the child has to be monitored every half an hourly, and once this correction is over, then you will again reassess the child, classify the child and plan accordingly. So, that is the correction in the plan C.
What if the child is having hypotension?
If the child has already gone into hypotension, the child will be having cold, clammy skin will be there, pulse will be either weak or very fast pulse will be there, and CRT will be more than 3. In that case, you can go ahead with the bolus doses of fluid, and usually we will be giving 20 ml per kg bolus dose over 5 minutes, and then you will have to reassess the child, and up to 3.
That bolus dose you can give just the plain NS or the ringer lactate. Okay.
And then you will reassess the child, and up to 3 bolus doses, that is 60 ml per kg bolus doses can be given for the child.
Okay, okay. So, so you have told about A, B and C. So where all will you consider admission?
In case of plan C, with or without shock, compulsory admission is required.
Okay,
and
plan C, that is severe dehydration. Plan
Dehydration.
C we will admit. Then
Plan B, if there is, if we are suspecting the child is having some toxic features with fever, if the child is having invasive diarrhea, if any of the altered mental status is there, all those things also plan B you have to admit.
or if the patient is worsening to plan C. Okay,
then in case of severe acute malnutrition is there along with this, then also the child has to be admitted and treated.
Okay, then if the child is less than 6 months, or if the child is persistent, continuously having diarrhea more than 8 episodes, because we don't know even after discharging whether the child will persistently have diarrhea or not. So more than 8 episodes in 24 hours also will require admission. Okay, then this is just admission. When will you plan on admitting to an ICU?
In case of severe dehydration with severe acute malnutrition, you will be admitting into the ICU
for monitoring of electrolytes. Then we need to admit to ICU, because as you told, in severe dehydration along with shock, even after 2 bolus, so maximum we can give 3 boluses, that is 60 ml per kg. So even after 40 ml per kg, if the child is having hypotension, then we will have to admit to ICU. Okay.
Then coming to the other treatments, that is the nutritional management. If as we have told, if the child is breastfeeding, we will continue with the breastfeeding. Then normal routine oral food intake should be started within 4 to 6 hours of the onset. And then all the home available fluids can also be given in plan A children. And then an extra meal a day with high energy rich food should be started and given up to 1 to 2 weeks even after the finishing of this diarrheal attack. Then coming to the zinc should be given for every children, because it decreases the severity, duration, and also prevents further episodes. So children less than 6 months will be given 20 mg per day, and less than 6 months will be given 10 mg per day for 14 days. Then coming to the probiotics are not usually preferred, but we can give, because it is effective in reducing the duration and intensity of symptoms, and usually we give lactobacillus. And then coming to the antiemetics, in antiemetics, if the child is having recurrent vomiting episodes, then ondansetron can be given at a dose of 0.15 mg per kg per dose. And it is effective in reducing the episodes of vomiting. And then the anti-secretory, anti-motility drugs are usually not preferred in pediatric age group. Loperamide, everything is contraindicated in the pediatric.
So what all things, anti-emetic you can give, ondansetron can be given, but other agents like what other anti-emetic should be avoided? Metoclopramide, prochlorperazine, these things should be avoided in case of children. Why? Because that can cause extrapyramidal syndromes, and respiratory depressions can also happen. So that should be avoided. Then we need to avoid the anti-secretory agents. Loperamide should be avoided. Why?
Because mucosal, there will be intravascular lossage will be there, and mucosal healing will be delayed. So
then toxic megacolon also can happen. So loperamide and resicodotril, those things should be avoided. Okay.
Then coming to the indications of antibiotics, in a routine basis antibiotics are not preferred, but there are indications where we have to give antibiotics. That is mainly considered when the age group of the child, that is the child is less than 3 months, when the child is having immunodeficient child, the child is having severe acute malnutrition, and if their child is infected with provenly it is infected with Shigella, Escherichia coli, Vibrio cholerae, etc., then we can give the antibiotics. So these are the only recommendations where we give antibiotics. Otherwise, routinely we are not giving.
Immune deficiency like sickle cell anemia, any malignancy, or any irritable bowel disease, these conditions also you can give. Okay.
This is the final chart of acute diarrheal disease management. So as we have already told, in no dehydration we will be proceeding with the plan A, and you will be reassessing the child after 2 days if the child is improving clinically, and if there is signs of dehydration or child is deteriorating, we will be going into plan B. As we have said, in some dehydration, first we will be going with plan B. After the 4 hours of giving the fluids, we will be again reassessing and moving into plan A, or continuing on plan B, or moving into plan C. In case of severe dehydration, we will start with plan C, and after the 6 hours of fluid resuscitation, we will be reassessing and moving accordingly. Then coming to severe acute malnutrition, when child of severe acute malnutrition presents you with acute diarrhea, we will have to look into the history. So we will be looking whether it is of that diarrheal episode is of acute onset, as like within few hours or days. We will be also looking the child's appearance, whether the child is having sunken eyes, and whether the child has eagerness to drink. And then we will be looking for the features of shock, that is cold hands with capillary refill time more than of 3 seconds and weak and fast pulse. So in these children with severe acute malnutrition, you will have to admit in a hospital and manage the child, and here you prefer oral correction, because IV corrections can cause cardiac failure and fluid overload. So we prefer oral hydration in the child, and if the child is not orally tolerating, then we can put an NG tube and give the fluids, and then you will be correcting the child at a rate of 70 to 100 ml per kg over the 12 hours, and in the initial 2 hours you will be giving 10 ml per kg per hour. And following this 12-hour correction, according to the child's thirst and according to the child's number of purging, you can adjust the fluid given. And here if you are giving ORS, you does not prefer giving ORS, because as we have already told, the concentration of potassium will be very low. So we will be giving Risomal in the child, and that you can dilute 1 sachet in 2 liters of water, and then you can give to the child. If at all it is not available, you can give our newer ORS itself, but when we give that, you have to dilute it in 2 liters of water, and also you have to add 45 ml of potassium chloride with 50 grams of sucrose, and then you can give to the child. So this is the management what we follow in the severe acute malnutrition for children presenting with acute diarrhea.
Okay. So any role for investigation? So we have discussed about the presentation and this thing. What all investigation will you plan, and what all will you send?
So coming to the investigation, routinely no investigations we prefer in children, but if the children is having persistent diarrhea more than 7 days, if the child is having toxic features associated with fever, if the child is having invasive diarrhea, and then if there is some outbreak in the locality, and then if there is an history of travel to the risk areas, and if the child is having any underlying chronic disease such as immunodeficiency or any malignancy, inflammatory bowel disease syndrome, etc., then we will go for the investigations, and we will be doing CBC, CRP you can do. Then along with that, we will be also checking the electrolytes. Before, we will have to check for the GRBS. If the child is very much drowsy, then first we will be looking for the GRBS. In case of fever and toxic symptoms, we will be looking for the CBC, CRP, and then we will be also looking for the electrolytes. Then you can, if there is any outbreak, then you can also look for the stool routine.
Stool routine and culture. Anything else? We will have to look for any dehydration features, any pre-renal failure or anything. So we will have to check for the Bun-Creatine ratio. So the renal function test, and also the lactate in case of hypotension. Okay. These are the maximum tests which will be required in a child, and if at all we are suspecting a surgical abdomen, then we will have to plan on any radiological investigations. Otherwise, these are the lab tests which will be required. Okay. Anything else? Thank you.